deployed there and all protocols are observed. Then I would also like to thank CKBTI for giving me an opportunity to get more training experience. I'd like to thank the organizers of the KNH webinar series for inviting me, Professor Violet Nanu for some of her slides, and the Almighty for his providence. I guess we can say thank you for him for this, allowing this to happen. So this is the outline of my presentation. We'll start with definitions, then we'll talk about what is research, why do research in humans, what is research involving humans, what is ethics, principles of research ethics, application of principles, and we'll finally come to a conclusion. Now, just have a look at what you see on the screen. I took a picture of this. This is a billboard outside near where I live. And you can see it's been written, "We won't stop until malaria is eradicated." Then you can see BAGON, protection for all. Let me ask a question and you can put it in the chat real quick, and Prof. Mukute, you'll help me with the chat. What is the claim? What are they claiming in this billboard? And do you believe it to be true? And if you believe it to be true, why? And if you don't believe it to be true, why not? If you could just put it in the chat, I'd be very happy. And Prof, you can help me see what people are saying.
Okay. Right, so far I haven't, oh yes. The first, it looks like malaria is a sexual transmitted disease. They claim to end malaria with their product. One claiming eradicating malaria. I don't think it's true. False claim, spraying mosquitoes cannot eradicate malaria. Okay, kindly.
Excellent.
Okay, all right. Not true, not true. Somebody said it's true. Okay, claim as business in advertisement, true. How hope they claim to, okay, we have quite a number of suggestions. I can hardly keep up, but we'll continue. Yes, they are claiming to, okay, there needs to be more information. They claim to want, okay, okay, BAGON does not kill mosquitoes, does not eradicate malaria. BAGON can't eradicate malaria. Appealing to emotions, no way. Combined effort, we can eradicate malaria. Somebody said that. Okay.
All right. Thank you so much, Prof. I think if you were to continue reading, we could read until the end of the session. So thank you. Thank you so much for your answers. Yes, and somebody was saying that it looks like sexually transmitted disease because maybe of the two people inside there. That was really funny. But if we were to go much further, if we had more time, we'd come to realize that perhaps BAGON has a conflict of interest because they're the ones who produce the insecticide, and they're the ones who are also advertising the insecticide. And a lot of the things that we're talking about here are actually, nobody has really talked about the science of it. What science have they done? People are just saying, look, it's not ethical. What are you doing? You know, what you're saying is not true. So this is the reason now why we need to do research in an ethical way, because people need to feel that our results are valid. And the only way you can get a valid result is if you have done it ethically. So let's go on to the next slide, which is definition of research. So when you look at the 45 CFR 46, this is the Code of Federal Regulations. It's a code in the United States. It gives the definition of research as a systematic investigation, including research development, testing, and evaluation, designed to develop or to contribute to generalizable knowledge. So the key word here is generalizable knowledge. Now, generalizable knowledge can also be called knowledge that is widely applicable. So you might be doing something in your laboratory, you might be doing something in your office, you might be doing a medical chart review, you might be doing a meta-analysis. But if it's not going to give rise to information that's widely applicable, that wherever in this world you go and you do the same study or you get the results of this study, it would be applicable to your situation, then that would not be called research. Another definition is from the Organization for Economic Cooperation and Development. And it says that research is creative work undertaken on a systematic basis in order to increase the stock of knowledge. So what are we trying to do when we're doing research? We're trying to get more knowledge about actually what eradicates malaria. Is it Baygon? Is it an insecticide? Is it everything that we have thrown at it, like bed nets, like medication? So that's what research it is. It is to increase the stock of knowledge. And in that increasing, you might be establishing, confirming, and reconfirming facts. For example, sickle cell anemia has been treated by hydroxyurea for years and years and years. But just recently, there have now started studies to confirm that hydroxyurea is actually suitable for treating sickle cell. So that is reconfirming facts. It can solve new or existing problems. Like when COVID came, we were solving a new problem. It can support existing or develop new theories, and it can also develop knowledge of the mechanisms of learning. So that's just another definition of research. Now, what does conduct of research, what does it entail? Well, of course, it entails the proposal, the research work. You write a protocol, you go out into the field and you implement it. That is research, but it also includes funding. It includes facilities. It includes materials. It includes communications, collaboration, and training. So when we are looking at a protocol, we don't just look at the research methodology. We don't just look to see if the objectives are going to answer the question. We also look at all of these other things, because if all of these things are not working well, it may mean that you're still going to be wasting the time of the research participant. So we've looked at the definition of research. We know we are trying to increase knowledge, and we know that also it's supposed to be widely applicable. Now, I've moved from one computer to another, so some of my slides might be a bit out of order, but this was just to compare research and quality improvement. Many of you I know, especially in the medical field, healthcare workers in hospitals, you are always trying to improve your processes. Now, quality improvement is not the same as research. And the thing that I just want us we're not going to go through all of this information, but let's just look at the purpose. For research, it is to contribute to generalizable knowledge. But for quality improvement, you have acceptable standards, and you're always trying to see what you're doing up to those standards. So that's one place they are different. Another place they are different is in the design. Let's look at the third thing, the design. With research, you're going to have a protocol which you must follow to the letter as much as you can. If you're going to change it, then you have to request for an amendment. But for quality improvement, it's usually very adaptive and it's very iterative, because you're trying to improve a process. In the benefits and the risks, they are usually not benefits to the people who are in the research currently, but they would be benefits to the people in the future. However, for quality improvement, whatever you're doing should benefit the process at the time, even though it may not benefit the patients. Research tends to put research participants at risk, not the same for quality improvement. Research, to be in research, you don't have to be in research. Your obligation is that it's voluntary, but in quality improvement, it really isn't. So I was just bringing these two because I know there are people who get confused and they submit proposals, and many of them are for quality improvement, but they're not really completely research. And I just wanted you to see the distinction. Same to surveillance. Generally, research tests hypotheses while surveillance generates hypotheses. So that would be the difference between research and surveillance. Today, we are talking about research. So research is systematic, and it gives rise to generalizable information. So why do research in humans? Well, to be very truthful, it is impossible to reach the important conclusions about humans without studying humans. Let's take, for example, if you're studying human physiology. You know, you really can't go to the baboon in the national park and say that you're going to study the physiology of the baboon and hope that the responses of the baboon are the same as the responses in humans. There may be some that are, but many will not be the same. So that is why we do research in humans. Secondly, if you're doing epidemiology, same story. You go to the national park, you look at baboons, and I'm talking about baboons because there are quite a many where I live, and you look at them and try to understand their epidemiology. But you know, if you're talking about human epidemiology, it depends on human susceptibilities and human interactions. So again, that is why we do research in humans. Then finally, when you want to test if a Coartem is working, you know, lumefantrine is working against malaria, or even the so-called Bagon with the mosquitoes, you know, you would only do it in humans because you do it in animals, but sometimes you cannot extrapolate the data from animals to humans. So that is why we do research in humans. So it's something which is sometimes a bitter pill to swallow, but at the end of the day, if you want to get the correct response, then you really have to do the research in humans. I want to give you another example. If you are going to do research in children or in the mentally impaired or in various ethnic groups or in the elderly, in women and pregnant women, breastfeeding women, you know, for you to find out which drugs a breastfeeding woman can take safely when she's breastfeeding, you need to do the research in the breastfeeding woman. So I hope I've cleared your minds about this idea of why must we do research in humans. Of course, AI has come, and they're doing a lot of simulations, and they are in the process of trying to convince us that we'll be able to shorten the amount of time we take to find out whether, let's say, a drug works, because we could probably use AI and do things just in the laboratory, but we haven't got there yet. For now, we do research in humans because that's where we can get the answer that are applicable to humans. So what is a research participant now? According again to the 45 CFR 46, a research participant is a living individual about whom an investigator, whether professional or student, conducting research does one, obtains information or biospecimens through intervention or interaction. So intervention is like if you're doing a clinical trial, you're giving people a vaccine, you're giving people a drug. So like during COVID, they were giving people the vaccine. Interaction is like when you're asking people questions or you're just observing them, you're interacting with them. If you do any of those two things, then you are that is a research participant. And then the second point is obtains, uses, studies, analyzes, or generates identifiable private information or identifiable biospecimens. So before 2019, the Code of Federal Regulations, or the common rule that we use to determine whether a person research is research and a participant is a participant, they didn't have the biospecimens, but now we have the biospecimens. So if you're going to get a medical record with my name on it, Caroline Kidinji, and you get female and everything else on it, and you get whatever information you get, then you cannot say that that is not human subjects research. It is, because you have my identifiable information. Even if you get my sample, if you get my blood sample and it has my name and you want to do research on it, I don't have to be there myself in person, but that is also research. So I hope I'm asking some questions which are commonly asked when people are submitting proposals. Now, before you, I'm going to give you a number of images, and they are going to be different images of different people. And this is what we normally get in protocol, something called an inclusion criteria. And in all of these images that I've brought before you, these people are vulnerable in one way or another. So for example, the people in both pictures, these are minors. They're probably between the age of maybe 15 and 18. And on the left, they seem to be in school. On the right, they're the same minors, but you can see they are expecting. Now, when they're expecting, the question is, do you go and ask their parents for consent? Or don't you ask their parents for consent when they're expecting? The ones on the left, it's a bit easier. You may ask the parents, but if they're in school, where do you find the parents? Those are some of the questions that we ask. Then there are a whole number of images here. On the extreme left, you can see a man who is elderly, and he seems to have cataract. In fact, he looks quite ready to go into surgery. Next to him are other elderly persons. On the extreme right, there's a young child being carried by their mother who is very happy, very comfortable, very content. And it looks like the mother is going for clinic. At the bottom of the page, there are some toddlers who are playing together. In the center of the lower line, you can see this person has passed away. He has a tag on his toe. And then on the extreme right, you have people who are waiting to see a doctor. These are all your research participants. And if we had time, we would go into why each one of them are vulnerable and what you need to do when you're actually working with these kind of people. And then finally, I have a page full of younger people. So we'll have the sick child, a sick infant, a well infant, school-going children walking up a hill. You can see the young Maasai little girls. They are very happy. These ones are completely minors, would have to get permission from their parents. Another pregnant adolescent. And the last picture is of street children. Again, various vulnerabilities. And these are the research participants that researchers in Kenya and Africa south of the Sahara meet every day. So you must take into consideration that you need to do a job that is ethical because already our populations are quite vulnerable. So let's move into ethics now. What is ethics and why is it important? The guy on the right here, who is having a bad hair day, is Albert Einstein. And this guy is the guy who brought into this world the atomic bomb. And this is what he had to say about ethics. He said, many people say that it is the intellect which makes a great scientist. They are wrong. It is character. So ethics is all about character, and it's all about the decisions that you make. I can see people laughing at my dear Albert Einstein, but he didn't care about his hair. He just went on. So let's define ethics then. We've heard about it in public health ethics. Prof. Buhudia also went through it when I was talking about clinical ethics. But I'll just reiterate again, there are moral principles that govern a person's behavior or the conducting of an activity. And in this context, we're talking about research, the branch of knowledge that deals with moral principles. So we're talking about what is right and what is wrong. Right doing and wrongdoing. Is it right to do research on very sick infants? Question. Is it right to do infants on people, on elderly people who have dementia? So these are the questions that ethics explains. Just to go back to say that ethics actually means character. It's from the Greek word, and it's the systematic study of value concepts, good, bad, right, wrong, and the general principles that justify applying these concepts. So there's a difference between morality and ethics, because in morality, it's just a question of what I think. If I say abortion is bad, and I don't have to explain to you why I feel abortion is bad. I might say it's because of my religion, or I may not. But if you're an ethicist and you're going to say abortion is bad, you need to have an argument. And you might say abortion is bad because life begins at conception and you're destroying a life. So you're using that principle of sanctity of life. So that's what ethics is. And there are some people who say a moral person knows what to do and does it, but an ethical person knows what to do but doesn't do it, because they'll get an argument to a counter argument to do the opposite. Research ethics then involves the application of fundamental ethical principles to research activities. So we're talking about ethics. And you can see here there's a balance. And I think it was Prof. Bukusi who was talking about making a road through the park, and everybody was trying to struggle to explain whether how they would do it so that you could balance the scales. On one hand, you might get a lot of money. On the other hand, you're destroying the environment. And for your information, Nairobi is the only city in the world that has a national park in its environs. Others like the US has Central Park, and the UK has Hyde Park, but they don't have animals in their natural ecosystem. So the principles, you've heard of them before, are beneficence, and we're going to talk about them more later, non-maleficence, autonomy, and justice. So we won't go into the details of them right now because I'll talk about them later. So how did we get here? How did we start talking about ethics, and how did it become such a big, enormous issue? So there's a journey. There's a journey to ethics in medicine and research. And you can see this is a really steep corner on the picture I've shown on the screen. And they've put all the signs to say that you're really going to have to turn. It seems to be high above. So that is how the journey of ethics has been. It's been quite a cliffhanger. So there are three main things that made us start talk about ethics. One are the historical scandals regarding medical practice and research. We won't go into details. I think they were mentioned yesterday and they were mentioned the other day. The medical advances, for example, life support machines and kidney dialysis. And I remember when I was doing my master's, they asked us a question, how do you know when somebody is dead? And it took us a pretty moment trying to describe why somebody's dead. Eventually, I just told them, when you see their shoe has left their foot, they've been hit by a car, kiatu iko kando, then you know this person is dead. In the end, a medical doctor explained to me why the shoe comes off. But it's because of these life support machines. You really can't tell when somebody is dead anymore, because they seem to be breathing, their heart seems to be beating, but they're not there as such. And finally, the human rights movement. The human rights movement, Wakina Martin Luther King Jr., those guys did a lot to try and bring people in a more equitable space, and ethics kind of rode on the back of that, the movement. So I'm not, again, going to go into the details of these historical scandals, but just to mention them. So there was the Nazi trials, there was the Tuskegee syphilis study and the Willowbrook hepatitis study. There was the STD study that was done in women in Guatemala. There was the tea room trade. This one was to do with a man standing in public toilets to see how men have sex with other men. And there was the Stanford County Prison experiment that was trying to explain why the Nazis were doing such terrible things. And if people will just obey commands, even though they are good, or if they are bad, if they could just obey commands because somebody senior had talked about it. And you can Google all of these historical scandals because they've been talked about, and I won't go into details. The only one I will talk about a little bit more is the Tuskegee study, 1932 to 1972. I'll apologize for my picture. It's pretty not so clear, but at the end of the bed, there's the chart for the patient, and it's saying, ignore this syphilis patient, experiment in progress. So what happens is they wanted to look at the natural cause of syphilis, and they went to a part of South America called Macon, where there were very poor sharecroppers, and they told them that they were being tested for bad blood. They were not told that there was syphilis, and these men had syphilis for 40 years. Many of them died. Many of them gave it to their children through their wives, and this was despite that shortly after they began the experiment, they discovered penicillin and they could have been treated. So this was very, very unethical. So this is when people began to say, can we really trust scientists to be their own judge about what is good and what is bad? And that is how come now the whole story of ethics began to take some ground. Some have happened in our own country. When I was learning ethics, this is many years ago now, they used to talk about these guys in the West, and I just think, whoa, these have got nothing to do with us. You know, why are they talking about these people? It was a long time ago. Accept and move on. I had that attitude until it came home to Kenya. And the first one is the children's home in Nairobi. And this was just a scandal of how the owner of the orphanage or the children's home was giving people blood. These were students from Oxford and professors from Oxford, and they were giving them this blood, and then they would give them money for the orphanage. So it did look like it was in exchange. If you look at the last sentence, it says, director of the home had been bleeding HIV-positive children with the help of interns from the United Kingdom in exchange. Hello?
No, I'm not able to.
In exchange for money for the institution. So this one even made it to the
more than an hour.
Prof. Muhuthia, please mute. Sorry. Yeah. Prof. Muhuthia. Thank you. Yeah, so this was even in the newspaper in 2013. Then there was the Majengo sex workers as well. And then the issue with this one is that these studies had gone on for very many years, for over 15 now, I think it's just 30 years. And many argue that the women were exploited by researchers because the women never did seem to benefit as much as the researchers. So this was another scandal that we could say was in our country. Then the last one was the cell phone data mining. And in this one, it looked like Harvard School of Public Health at Cambridge admitted they used unauthorized data to conduct a survey on how malaria spreads in Kenya without informing the participants. So what happens is that they say that between June 2008 and June 2009, the researchers mapped every call or text made by each of the 14 million Kenyan mobile phone subscribers. But there was no message from Safaricom saying, oh, we are going to be doing this experiment. We are trying to see how malaria is spreading. So we are going to be using your data and we are going to map your telephone calls and your text. There was no message from Safaricom saying that, and they carried on with the study. So again, this is unethical, and I can see the reactions that, my goodness, what was going on? And this time we had the guidelines. We had all the guidelines, and people were aware of the guidelines. So it's not just about being aware of the guidelines. It is practicing what you preach, practicing the principles. So anyway, out of all of these scandals, not the recent ones of Kenya, but the ones from before, we got a number of codes. And that is the Nuremberg Code. That would be the very first one. It had 10 commandments, if I can call it that. And then there were the Symposiums, one of the later ones. There was the Declaration of Helsinki, which has been revised severally. The Belmont Report, which is just 32 pages. I like this one because you quickly can find out what is going on. Research Ethics in Africa. This was an attempt to write something that was more contextual for Africa. And then the ICH. The ICH is used mostly for people who are doing GCP and they're doing clinical trials. So these two gentlemen, Tom Beecham and James Gilchrist, may they rest in peace, they have all passed on, eventually were told after the Tuskegee, they formed a national commission in the United States of America to look at these research ethics things. And they were asked, they were given a consultation to try and simplify or to make ethics more applicable for when you're doing research. Because they said maybe people know the ethics, but they do not know how to apply it, because if you're talking about an ethical theory, it will take you very long to apply it. So they call them the biomedical principles. And the approach came to be known as principlism. Okay, this is not to say that these ideas were not in the air before Beecham and Childress, but it's just that these people put them in the book, they wrote them down, and they had been given the authority to write it by the government, the United States government, and that's how come eventually it kind of stuck. So now when we're talking about the principle of ethics, we do talk about Beecham and Childress. And these are the ethical principles. There's autonomy, there's beneficence, there's non-maleficence, there's justice. I add on two more: veracity, which is truth-telling, and fidelity, which is promise-keeping. Now, the last two, I add them because when I talk about research ethics, you can't go away from talking about research integrity. And research integrity requires you to be truthful in what you do and requires you to follow your protocol faithfully. So that's how come I've started tacking them on whenever I talk about research ethics. So let's start with respect for persons or autonomy. They are not really synonymous, but it started out as respect for persons. But by the time Beecham and Childress were writing their book, they called it respect for autonomy. For autonomy. And really, respect for persons is just a matter of human dignity, where you recognize that all persons have dignity or inherent worth. Now, this is difficult. And I remember, I'll give you an example when we had just begun doing research with men who are having sex with men. And the reaction by the community and the reaction of also our fellow researchers was very interesting. I mean, they felt that these people are doing the wrong thing if you come from a religious point of view. And it looked like Kemri was condoning their activities because they were doing research. And it's only because when they would come to our clinic in Mutwapa, we'd treat them like normal human beings. When they would go to other hospitals in Mombasa, they would be the last to see the doctor. They would have insults hurled at them because of people's view about what they were doing. It's difficult to accept that people who are doing things that you don't think are correct actually have inherent dignity or worth, but they do. So this is what you need to do when you're respecting a person when it comes to research. So you respect them because they are human. You don't respect them because they're doing the right thing, or you don't respect them because you like them. You respect them just because they are human. And as you know, dignity has got no degree. Nobody in this world has got more dignity than the other. Me and Michelle Obama, former First Lady of the United States, we have the same amount of dignity. We clearly don't have the same amount of influence, but we certainly have the same amount of dignity. So this is what you're respecting. And that is how respect for persons is closely tied to autonomy. Because when you're talking about autonomy, it means that you are allowing me to make a decision on my own life, and you are going to respect my decision. I think it was yesterday that Prof. Mukudia was talking about somebody who their religion did not allow them to take blood, and they died because they did not get the blood and they needed it. So it was a very difficult thing to do. But in the end, Prof. Mukudia and the team respected that person's autonomy. And autonomy is preserved through informed consent. I just like tacking on this young lady here on to demonstrate that autonomy is, is a moving goalpost, because women have becoming more or less have more or less autonomy with time progressing. There was a time when my mother had to get my father to write a letter for her to open a bank account. But of course, now I don't have to do that. And then there used to be a time that the father would have to write a letter before the child leaves the country. I think that still happens, but that's to do with the child. So autonomy is also something which is easy to say, but not as easy to practice because of the context. So autonomy means self-rule, right to self-determination, treat each individual as an autonomous subject, and they have a right to make decisions, but you have to remember that they also need to have the capacity to make those decisions. And that is why I was showing you all of those pictures of people who are minors. And I was talking about the elderly. In emergency medicine, you come in and you know certain things have to be done to you, very serious things. You are not awake to make the decision. They are looking for your next of kin. You don't have the physical capacity. Sensory capacity, you know, of course, these days things are a little bit better, but if you are blind, if you're deaf, you know, there are issues of that. Doesn't mean that your brain is not working, but now the communication can be difficult. Then you need to give them information and you need to allow them to act voluntarily. But it is challenging to apply this principle of autonomy. I include this paternalism and parentalism because it is a principle of ethics, but it might sound like it is contradicting autonomy. But there are certain instances when you need to restrict somebody's autonomy. And I'll give the same examples of people with dementia, people with Alzheimer's, or people who are very, very unwell, or people even whom their child is very sick or they are very sick. There's a sense in which there has to be some kind of a compromise between their having full autonomy and you being a little bit paternalistic, where you say that you are making the decision for their good, but they're not the one making the decision. And you can see the scheme on the right. You have paternalism on the left, where you have the physician who is the guardian, who knows better, who decides to protect. And then there's autonomy, where the physician listens, talks less, listens more, and identifies patient preferences and values. Then in the middle, you have the shared decision-making model. I think this is a big headache to physicians these days. Yesterday, I had somebody talk about Dr. Google. And Dr. Google is quite something. We all think we know what we're talking about, and we go mouthing things to the doctor. We have got no experience, but there you go, we have our knowledge. But when you're talking about the decision, now we are moving to the place of shared decision making. So this should also be for your research participant. Don't come with this feeling that you know everything. You're the one with the 12 years and more of education. You have written this protocol, you know what you're doing, it's been approved by the ethics committee. You need to come to a place where both of you are happy with the decision that is being made. Beneficence and non-maleficence, do good, act in a way that benefits patients or participants. It is the centerpiece of risk-benefit assessment. It's closely related to non-maleficence. And if we had time, and I think Father Mark is on this call, we would start discussing until the cows come home, what is good. But we'll move on because of time. Non-maleficence is do not cause harm, prevent harm, remove harm. And it's more binding than beneficence because you're going beyond just trying to do good to the patient, you're trying to prevent harm. So this is where we ask you questions. What are the risks to the participants? What are the benefits? And is that ratio acceptable? Justice when it comes to research ethics is quite a complicated concept, but just go home knowing that you need to treat alike cases alike. So it doesn't matter who it is who has, let's say, the malaria, or who it is who has the pneumonia, whether it's somebody with more influence or somebody with less influence, you're supposed to treat them alike. They have to go through the screening process the same way. They have to take their medicines the same way. They need to follow the rules of the protocol the same way. So you need to treat them alike. And also, you shouldn't go where it is easier to get research participants. So informal settlements are the easiest place to get research participants. Why? It's because they are not going anywhere. For sure, they are not going anywhere. They don't earn a lot of money. You come here today, tomorrow, until forever you'll find them. As opposed to maybe somebody in Runda, somebody in, higher up in the scale who would be out of the country tomorrow, today. And if you want to do research on them anyway, you can't get past their electric fences anywhere, and they are curly dogs. So this question of justice is a little bit difficult to apply, but just go away knowing the takeaway message is that you need to make sure that when you are enrolling somebody into a study, it's not because it's convenient, it's because that they meet the criteria of the inclusion criteria, right? So that's why you're doing. And if you're excluding somebody from a study, you're excluding them because they will be in a lot more harm and not because they have a little bit more money. So my last two that I just put here because of research integrity, you have a duty to be faithful to commitments, make a promise, follow through, duty to the protocol, duty to ethical principles, duty to the research participant. So that's what we mean by fidelity. And then veracity is truth-telling. And this one is that you need, if you have made a mistake on your protocol or your things have not gone right, you need to be open enough to say that you've made a mistake. And then the whole story of plagiarism, falsification, the other one, I think it's called fraud, all those things, you need to take them into consideration when you're an ethical scientist, and tell the truth and do it the way you're supposed to do it. I have a very small case study here, just to explain to you how difficult it is to apply some of these principles. So whether you're a creationist and you believe that in the beginning God created heaven and earth, or you're an evolutionist who believe there was a big bang theory, there was a lake, and then there was a bang, and then there was a lizard that came out of the water and turned into a bird, and then turned into all the various things that we have on earth. I'm simplifying everything. I'm not necessarily being very truthful in the way I'm expressing it. There is one thing that we have in common, and that is DNA. Whichever way you go, this molecule is going to be part of any of those two stories. And this Human Genome Project that came from 1988 to the year 2000 really exploded science. And now they mapped the whole genome, and they knew all the genes that were on it, and they knew what many of them did. They still don't know what all of them do, but at least they knew what they were and how they looked like and that kind of thing. So this really made science change quite exponentially, because it means then you could just go to the gene that is causing the problem, remove it. And yesterday, I think somebody was talking about CRISPR, or in the day before in public health ethics talking about CRISPR, remove the offending gene and put in the correct gene, and voila, you're better. So there is a successful story about how that happened. And that is Ashanti at 4 years diagnosed with severe combined immunodeficiency. It's called SCID, and it's caused by that gentleman there. I'm not going to say his name. And you can see her there inside her little bubble. They had to keep her away from the normal environment because otherwise she would just die because she had no immune system. However, now after this human genome story, they were able to expose her white blood cells to a genetically engineered virus that replaced the faulty gene with the correct one. So they took out her blood, they went to the laboratory, and they did this genetic engineering. And it worked out well. She got better. And you can see her in the picture here in 2013. First gene therapy patients attend the IDF. And then you can see her here also a few years later. She's a great advocate for gene therapy. She has to go back every so often to make sure that to go through the procedure again, but she's alive and well. So people were very excited, and many more people were doing gene therapy. Then this guy joined a study at the Johns Hopkins. He was called Jesse Gelsinger, and this is now in 1999. And he suffered from something called OTC rather, and that causes ammonia to accumulate in the blood. Soon after, they injected him with the vector that was supposed to exchange the gene so that they can remove this OTC and put in the correct gene. He developed high fever. His immune system went out of control. His blood began clotting. His ammonia levels climbed. His liver hemorrhaged, and there was a flood of white blood cells. So it seemed like he had some kind of cytokine storm. Doctors are not sure what happened, but suspected that his body reacted to the adenovirus vector. Now, this poured cold water on gene therapy, totally. And in fact, some people wouldn't even put on their CV that they'd done anything with gene therapy of that sort because they knew they would not get a job. And it was also mentioned that maybe there was some kind of conflict of interest, but you can just Google it and find out the story in completion. Anyway, so still people continued with this work of genes, and you come to hear of something called pre-implantation genetic diagnosis. So it's a technique where you identify genetic defects in embryos before going through IVF. So these are people who are doing in vitro fertilization. So they're unable to get children on their own. And so now they are going through IVF. So if one or both of the parents have some genetic abnormality, they might decide to do this pre-implantation genetic diagnosis. So this suggests that you have a choice after you've done it, this PGD, and you find something that you think is unsavory, to say, I do not want that embryo to be implanted, and possibly that embryo would be destroyed. So only unaffected embryos are transferred to the uterus for implantation. So I've just said that, and that's just a schema of how it happens. So this seems like good news, doesn't it? So let's, again, I was half an hour late, and we just have 10 minutes to the end of the webinar. So I'll go through this really quickly. You won't be able to answer all these questions, but I'm asking you a question. Would you do pre-genetic testing for cystic fibrosis? Now, cystic fibrosis is a genetic disease where people don't really go past 21 or 22, and they produce a lot of mucus in their system, and often at the end of the day they must have a lung transplant. So it's very difficult for the child. So would you do it for cystic fibrosis? Would you do it for Down syndrome? When you have that extra chromosome and your child has Down syndrome, sometimes they have difficulties talking, learning, sometimes they have problems with their heart, but I have a relative who's lived past 60. Would you do it for sickle cell anemia? And we all know about sickle cell anemia. We are from Kenya, Africa. Would you do it for migraine? Would you say, I would not like my child to suffer from migraine? This is quite a debilitating condition. I know a friend who would not even go to work for 2 weeks because of migraine. Would you do it for gender selection? And you know, in our culture, we really like boys because they are going to pass on the genetic line. As so the culture says. Or would you do it for the color of the eyes? If you hear that people who had blue eyes are much brighter than people who had brown eyes, would you say, okay, I want my child to have brown eyes? And we don't have time. I'd have told you to put it in the chat. We would have talked about it a little bit. I'm sorry, but technology came in the way. So you answer it yourself. You can type it or not. You can think about it. You can write these things down. You can ask yourself this question. But the next slide shows that where now ethics comes in. Because for cystic fibrosis, you could have an argument that this child is going to have a very difficult life and is not going to live past 20. So, oh my goodness, why would you do this to the child? Why would you do this to yourself, right? But when you now go to Down syndrome, it's a bit trickier because I told you my cousin has lived until past 60. So, and they may not have those heart issues, or even if they do, there's a way of dealing with them. So maybe you should not deny this person life just because they have Down syndrome. Then sickle cell anemia is treatable, not really treatable. They just look after your symptoms. You heard me talk about hydroxyurea to stop those crises that they have, the vascular crises that they have, to reduce the pain. And people can live for quite long with sickle cell anemia. It's troublesome, but they would still live and still be able to contribute to society. Now, when you're getting to migraine, you're now getting below the line, 100 Are you going to refuse to have this child, this embryo implanted just because they might have a chance of getting migraine? So things are really not getting better. Then gender selection is totally below the line. Like, really, I mean, is that what you're going to do? And yet there's some people who would say, yes, that's what I'm going to do. Remember the Chinese, when they had the one-child policy, they were killing off the girls. Right now, a Chinese girl can marry 100 men, you know, because the ratio, not really 100, the ratio has been so skewed because they were aborting girl children, they were killing them when they were born, there was infanticide, there was genocide. So gender selection, you might think it's not important to you, a child is a child, but there are certain people who might do it. Then, of course, the color of the eyes, that one now is really beyond the pale. But you see, this is what is called a slippery slope, ladies and gentlemen, and that's what happens in ethics, you know? And that is why we must have ethics. You need to have people who are thinking through these things, because scientifically they can be done. Scientifically, they can be done. But, you know, there are going to be some ethical repercussions for doing them. So this is the question we need to ask, ladies and gentlemen. Just because it can be done, does it mean it should be done? That is the question. Just because it can be done, should it mean it should be done? Does it mean it should be done? And this is the question why we have these webinars where we talk about these things so that you can go home thinking about it. So that ethics is not just for ethics review committee meetings and for protocol writings and for members of ethics committees and for whatever. It's for all of us, especially you scientists, especially you doctors that I'm talking to. You should be asking yourselves this question and asking, is it right? Is it wrong? Is it good? Is it bad? What are the implications? What will it do to our society? Thank you for listening. I have talked like an AK-47 so that we could be finished in 1 hour. And we have maybe like a few, like 7 minutes left. And I'll hand it over back to you, Prof. Muguvia. No, I can't hear anybody. Prof, I can't hear you.
Oh, sorry.
Okay.
Yes, I was unmuted. Yeah, so thank you very much, Caroline. We appreciate you going through the topic. Yes, you went very fast, but I'm sure that most of us got most of what you were explaining. Our apologies again for the lost time, but now we shall open the field for questions. We have had a few questions, and I would like to read some of them. The first one that came up, this was, somebody, Frederica, asked a question: what's the difference between unethical and inhuman?
They are very close relatives. When you're talking about something inhuman, it means you've gone against the human being in a way that has degraded them, in a way that has harmed them beyond. So, you know, when you say something is inhuman, I'm trying to think of an example and I can't right now, but it's very much tied to ethics. Whenever you talk about right or wrong, it's an ethical or a moral issue. And ethics is right inside that moral philosophy place. So they are more or less the same. I guess the some things that are unethical are not necessarily inhuman. But all things that are inhuman are definitely unethical. I hope you get that distinction. Thank you.
Thank you very much. I would add that when you address the issue about human dignity, inhuman thing, what is inhuman means that you are violating somebody's human dignity. You are not respecting that person's dignity. That would almost equal to inhuman things. As our speaker had mentioned, that a human has dignity, and because of the fact that they are human. So when you are doing things that are not human, it is violating that person's inherent dignity as a human being. Thank you. The next question is that, would you consider the failure to report or publish research studies unethical as an ethical violation?
Yes, that is definitely an ethical violation because you have used people's time, you have used resources, and then you do not tell us what you found out. So that is on one hand. On another hand, is that presumably what you are going to do was add to the stock of knowledge. So now there's something we don't know that we needed to know to go forward with whatever issue you were doing researching. So in as much as you can, I know writing is a big of an issue, and sometimes it's difficult to get things published, but in as much as you can, get it out, disseminate it. And because writing will last forever, when you speak, like now I've spoken today, you may forget it even in the next 5 minutes. But if something is written, you can refer to it once again. So yes, it is unethical. Thank you.
Okay, thank you very much, Caroline. Somebody has said that how can we get the learning materials? That one I will leave to the administrator to answer, hopefully before we leave. The next question is, somebody says, thank you for the presentation thus far. Kindly elaborate more about migraine. I didn't get it clearly. Thank you.
All right. So when it comes to migraines, these are really, really, really powerful headaches, and they can incapacitate a person when they get it. And there are some people who actually do not have a poor quality of life because they suffer from migraines. And the medical doctors will probably tell us how they come about and what one can do about it. So it's an ailment, it's debilitating. It might stop you from living a rich life or a full life. And so the question is, if you are told that you and your partner, you are trying to get a child through IVF, and they find that the gene for migraine, let's say, has become dominant because both of you are recessive for migraine. So now it looks like your child will be suffering from migraines. Would you still implant that embryo? That would be the question. And if the question is no, it's because you'll be saying, oh, I don't want my child to suffer. I don't want to bring somebody to this world who's going to suffer from migraines when I can clearly do something about it. Thank you.
Okay, thank you very much for that answer, Caroline. I don't see any other question on the chat. And we just have 2 minutes before our time is up. Caroline, yes, we don't have any other question on the chat, but you can, if there is anything else that you'd like to say about the topic, then I'll give you the 1 minute to say.
1 minute, yeah. So I saw a few other questions. I saw a question about community involvement in research ethics. It is integral, it is paramount. It is something if you don't do, then you are really not going to get the results that you thought you should get. Where do we drop proposals here in Nairobi? Where do we start? There are now, I think, 45 ethics committees that have been accredited, but KNH is one of them, Cambridge is another one, Aga Khan University, Strathmore. There are very many that actually have that opportunity. And then what is the redress available for research participants in case of ethical violation? There should be a number of the ethics committee on the informed consent that will allow you to call, that will give a number for you to call if there's been a problem. So unfortunately, we don't have time to talk about the slides, the trainings, but I think they were talked about a lot yesterday. That was the only thing I would have added. But other than that, thank you very much. Yes.
Okay. Yes, thank you. I think the question that you have that has been mentioned about redress for participants when there has been some violation. Yes, the research ethics committees that approved the protocol would be able to assist that person about redress. And also NACOSTI, the National Commission for Science, Innovation and Technology, or Science, Technology and Innovation, is the body that is mandated by the government to govern and regulate research. And the research ethics committees do their work on behalf or delegated by NACOSTI. So the redress can be also be directed or can be directed to NACOSTI, and they would be able to take action on the research or the on the ethics violation, or in the assist the participant who feels that they have that in one way or the other they have been violated. Thank you very much. And yes, so I think we our time has run out, and I would like to thank the presenter very much. I can see clappings going on, bouquets going on, and appreciations coming up to Caroline. And we yesterday we indicated to you that we have certificate courses which we conduct throughout the year, where there is also postgraduate diploma and master's degree courses in bioethics, both at Mount Kenya University, Amref International University, and University of Nairobi. Thank you very much. And I would like to take you back to the administrator and call this, mention that we end here, our presentation will end here. Thank you very much.
Well, thank you so much, Prof. Muhutia and Caroline, for the session. Kindly take back our appreciation as the KNH team to your Camry team for these presentations. They have been insightful. As we are closing, we'd like to notify you that we have an upcoming session on Tuesday. That will be the resumption of the Cervical Cancer Awareness Month. And the topic is as displayed on the poster. Kindly look forward, out for the emails, reminder emails and WhatsApp notifications that we'll be sending to you so that you can join us. Thank you once again for joining us, and do have a wonderful weekend.
Thank you very much, Kwaheri.
Thank you, na kwaherini.